We are live.
Good morning. This is Senate Judiciary. It is February 7th, 2023. We survived Groundhog Day, the coldest day in Vermont in about 10 years this weekend. So we're all here. Welcome. I know our first witnesses are all from the Department of Public Safety. And I will start with Daniel Baptiste. And if you want to call on others, when you speak, just identify yourself for the record. I know that Colonel Birmingham, Major Whitcomb, Morning Fox, and Wilder White are all on Zoom. So as is Eric Fitzpatrick, our Lake Coast.
Thank you very much. Good morning. Thank you for the opportunity to be here with you this morning. My name is Dan Batesy. I'm the Deputy Commissioner of Public Safety. And I wanted to start out by saying that.
Let me introduce ourselves first. Dan Cisco been here this year. Senator Ruth is right there, but he's not here right now.
I'm Senator Hashim from Dummerston, representing Windham County.
Dick Sears from Bennington County.
Senator Tanya Vyhovsky, representing Chittenden Central.
Bob Norris, Franklin County.
So please go ahead.
Thank you very much. I wanted to start out by saying that the Department of Safety, Public Safety is incredibly sympathetic with the issue that this bill represents. We feel that assuring workplace safety for healthcare workers is a high priority. We feel that efforts to do so are a team effort that combines all of the organizations that you'll hear from today, including law enforcement, and we take that very seriously. I'll also say that I spent the first half of my career as a street paramedic working in Syracuse, New York. So I know what it's like to be on the assaulted edge of a difficult patient and get punched in the face and all of that. So I come to you with a great deal of sympathy and understanding of the situation at hand. That said, I wanted to bring up some concerns we have regarding the implementation of some of the aspects of this particular bill and some difficulties that we see, especially on the enforcement side, the law enforcement side. I think the biggest challenge that I would suggest is what to do with a person once an arrest has been made. First and foremost, the patient is in the hospital for presumably a reason. They are being either evaluated or treated for some medical problem. They are difficult, have a problem with an employee, and the notion is that we would arrest that person and remove them. The problem is when we remove them, we have little that we can do with them. First of all, the care needs to continue, right? The treatment that is ongoing needs to be completed, and whatever evaluation is ongoing needs to be evaluated. If we take them to a jail, they're going to need to be medically cleared first. If we take them to a substance use facility, they won't be accepted if they have this assaultive posture that presumably the reason that we're involved in that situation. So that's the big challenge. The second challenge, as I see it, is oftentimes these situations are incredibly difficult to understand the determinants of the assaultive behavior. So again, as a paramedic, I can't tell you how many times that I've had to deal with a person that is assaulted for reasons that are either truly medical. A person who's a diabetic gets combative when they're having a hypoglycemic event or something like that, or psychiatric. And even a psychiatric issue, it is the behavior that we're responding to, but it represents a symptom of a larger illness. So again, if we apply a law enforcement solution to this person, presumably we still have to treat that psychologic or psychiatric underpinnings of the difficult behavior. Just apologies, go ahead.
You're assuming that all of those that are committing workplace violence in our healthcare facilities are patients. They're not. Many of them are family members, many of them are friends of the person. Maybe they're upset because they don't feel that their family member is getting the services they deserve, or maybe they're upset because they're just upset. So I want to make clear that it isn't just patients who are the ones who are committing some of these assaults. That definitely there are patients, and I understand. When we were testifying to healthcare providers, a number of them mentioned family members. There was one family member who said, if you find my son has a psychiatric problem, well, I'm going to kill you. It had nothing to do with the son, or what they found. He was presumably behaving well.
I think that's a fair point, Mr. Chair. And again, certainly something that I've experienced. However, I think that line is a bit fuzzy when we start talking about the application of this. I think there are times when it's black and white. I think there are times when this guy's just a jerk and he deserves to be part of the criminal justice system under those circumstances. And I think under those circumstances, there are reasonable steps that we can take from a law enforcement perspective. I think though, or at least it's been my experience in this world, that the days where it's black and white are few and far between, and that the vast majority of these situations are somewhere in the middle there, and oftentimes represent a confluence of both psychiatric and substance abuse, and oftentimes medical situations that complicate this issue greatly. So I think that's a large hesitation on our part about how to apply this properly, and how to navigate these folks once they're in the system, once they're in our care. We're also concerned about the liability. So if we remove a person who's presumably there for a medical condition or even a serious psychiatric condition, and they have a problem downstream in our care, that's going to be a significant challenge for us too. Again, we need to make sure that they're medically and substance abuse cleared before we can manage them in a long-term perspective. So I think that's the broad strokes and the major elements of our concerns around this. But as you pointed out earlier, we did bring a number of our team members with us today. So we have Colonel Birmingham and Major Wickham on the line, and also Wilbur White as well. So I don't know if you want me to turn it over to.
Yeah, I do have just a few thoughts and questions I wanted to put out there that either you can answer, we can punt it to the next person from DPS. My first thought, has to do with what you raised initially with, what to do after the arrest has been made. And, I think that, when you're thinking about a simple assault that's taking place in an ER, or somebody who's, throwing chairs or acting violent, there's a huge difference between showing up, handing a citation and saying, all right, see you in court in a month, versus physically removing that person from the facility, fingerprinting them, processing them for 2 hours, and then, calling for conditions. Maybe they'll get held without bail, or maybe they'll be released. But I think breaking that, having that interruption of the violence and removing them from the place is essential for making sure that hospital staff can continue to do their work and providing care for other folks. So that's one thing I wanted to put out there. The other thing that I agree with you on and also share some concern has to do with the being medically cleared and the liability piece, because it's going into a hospital and removing somebody who's either a patient, well, in this circumstance it would be a patient, removing somebody who's a patient without having them be medically cleared first, that could be definitely a concern. And one of my thoughts is putting in a line or a provision, saying that if somebody's going to be removed from the hospital, they have to be medically cleared first by hospital staff. Do you have any thoughts on that?
Well, so to go back to your first point, I would say, again, if it's black and white, I think that makes a lot of sense. Yeah. However, it's not been my experience that it's ever that black and white. If we're talking about a person who's been brought to a hospital, there's typically a reason why they've been brought to the hospital. They're having a psychiatric breakdown, they're having a medical condition, they're having something that has brought them there for evaluation or treatment. I agree that we have to interrupt that cycle of violence. And certainly, I don't want anybody to get injured by a person in a hospital setting. We fundamentally agree on that. The challenge is differentiating that person. And again, if they're just a jerk, let's go ahead and exercise the law on that person. But for everybody else, there is going to need to be some kind of a medical clearance. And I think it's very difficult for us to take custody of a person when that hasn't been completed. And I'm sorry, and also to follow through with all of the other pieces that bringing into a jail setting or any of those things. And I would ask Colonel Birmingham to chime in on the particulars of that if he has more to add to it.
Great, and so I guess, if there was a line that says that an individual has to be medically cleared first before being removed from the hospital, would that alleviate some of the concerns?
Well,
Would you want to talk about that?
I think I probably want to talk about that first. I think you should also talk about the healthcare talk to the healthcare providers about that as well, because my sense is it's probably going to be very difficult as well to create that state of black and white in this dynamic and sometimes dangerous situation. I think it's going to be very difficult. But I would say ask about it.
Awesome, thanks.
Colonel, or anyone else who'd like to weigh in? Major.
Good morning. Can you see me okay?
Colonel and Major.
Can you hear us?
Yep, and Wilda White is with us. So any comments that any of you have on the testimony so far on the bill?
Good morning. Can you hear us, Senator?
Pardon?
Yes, we can hear.
Yep.
Okay. Good morning. Thank you for having us. I'm Matt Birmingham, the Director of the State Police, with Major Wickham, who's our Field Force Commander. I don't have too much to add. I think I want to reiterate that we all want the same thing here. I think is important to state that nobody wants violence in any workforce, but especially in a medical setting. So we're all trying to head towards the same direction here. I think the challenge is, to the Deputy Commissioner's point, there are black and white cases where it's quite simply just a family member who's upset that commits a crime, and that's fairly easy for us to manage. It's the gray areas that are complicated, and those who are there seeking medical treatment. I completely agree with Senator Hashim's point that we have to stop the cycle of violence. The problem with that is, if we are removing somebody before they're medically discharged, we accept the liability of that, which no police officer in Vermont is trained to manage somebody who needs medical treatment. We don't have the ability to place them anywhere. And arguably, because it's a misdemeanor, they will not be held on bail. And the other issue is conditions of release. I would find it to be challenging, if not impossible, for a judge to impose conditions of release that they're not allowed to go to an emergency room as a condition of a release, because it's probably illegal. And if they had a medical condition and they're not allowed to go to the emergency room, which is where they would have to be prohibited from going, it's likely that would not be set as a condition. And they could end up back there and not be in violation of their conditions of release. So a couple of challenges I just wanted to highlight, but I know Wilda has some things she'd probably like to say as well, so I'll turn it over to her.
Thank you, Colonel Birmingham. Is it okay, Senator Sears, if I proceed? I see there's a hand in the room.
Go ahead. I didn't see a hand.
No worries. Colonel Birmingham and Major Whitcomb, one of the things that we've heard a lot of is sort of these instances where someone is brought in by multiple police officers who just leave them in the emergency department and leave. And I'm wondering if you can speak to why that might happen, or what, perhaps it's a training issue, or to really have officers evaluate when they need to be present, not necessarily putting someone in custody, but present to help maintain the peace.
I think it's as simple as it's a resource issue. We are, most law enforcement agencies in Vermont, including the state police, are substantially understaffed right now. And these are police officers and troopers that are on a shift that are covering calls for service. And we don't have the luxury of having them stay at the emergency room for hours and hours and hours, because we have other calls for services coming in that we must respond to. And so I would suggest that it's likely a resource issue. And I see Chief Allen's on the phone. He can speak to municipal police, but for us, it's a resource issue. When you have, 3 troopers on in a barracks covering an entire county, we can't have them sitting at an emergency room for 3 or 4 hours. It would exhaust our ability to manage our other calls.
Chief Allen, did you want to comment?
Specifically, thank you, Chair. On this particular question that regarding the and I'm sorry, I've lost my train of thought now.
The leaving the 5 what was reported in our hearing on last Wednesday was 5 officers brought somebody to the emergency room. All 5 left. So it must have been a pretty serious case that 5 officers brought them. And then the hospital staff was assaulted.
Yes, I'm sorry.
I think is, why did the 5 officers leave? And was it necessary? If it had been necessary to bring 5, maybe 1 could have stayed. And
the point, Chair, that I wish to make is that here in Chittenden County, at least, the UVM Medical Center has notified us and notified law enforcement specifically that we are to leave the emergency room at the soonest possibility. They had issues regarding their insurance and their payers of bills, if you will, that having law enforcement, especially uniformed law enforcement, in the emergency room was a violation of HIPAA, and we were told very specifically that we had to leave the ER at our soonest possibility. But I do also want to echo the sentiments of the Colonel that resources certainly do play a role in this, and for us to have 5 officers up there, at best we would have had 2 from Colchester and 2 from Burlington and probably one from Winooski. So, I mean, 5 officers is an awful lot in one place at one time.
I don't know that all 5 would need to stay, but perhaps 1.
There's conflicting testimony between last Wednesday and today about the Southwest Vermont Medical Center in Bennington. The CEO reported a $400,000 contract between the sheriffs and the Bennington Police Department to provide services from law enforcement at that facility. I believe there is a problem if the state were to hire officers to go in. I think that was part of the problem, but so I don't understand why UVM would be different from Southwest, but we can check that with the Medical Society or the Hospital Association. Wilda, you were about to testify.
Yes, thank you, Senator Sears, and thank you for the invitation.
Good to see you again.
Nice to see you as well. So my comments mostly go to I think exclusively go to the situation where the person that may be subject to arrest is a patient. And I know full well that that's not all of the circumstances that are addressed by this bill. And I just want to reiterate that, the department does very much stand in solidarity with healthcare workers, and we want to do all that we can to ensure their safety. And there's just some concerns about, and many of them have been voiced, but I want to maybe bring some of the legal realities into the room as we discuss these issues. The first is, if it's a patient, arresting a patient and removing the patient from the hospital emergency department before a patient is stabilized likely violates the Emergency Medical Treatment and Active Labor Act, something that's known informally as EMTALA. EMTALA is an act of Congress that requires hospital emergency departments to provide appropriate medical screening to anyone seeking treatment for a medical condition. And under EMTALA, you cannot discharge or transfer a patient needing emergency treatment except with informed consent or after stabilizing the patient or when their condition requires a transfer to a hospital better equipped to administer the treatment. Now, there is an exception in EMTALA where a hospital can delay treatment if it's necessary to prevent the patient from escaping, for example, if they are under arrest, or for harming others. But the treatment can only be delayed to prevent patients from harming themselves or others. And so I think for this to work for patients, the bill would need to recognize that a patient couldn't be discharged for arrest if their condition had not been stabilized without violating EMTALA. The other problem is, I think, with patients and with EMTALA is if you're asking, logistically, would you be asking police officers to come to the hospital to wait until patients are stabilized before they're arresting? And then how do we manage just the demands on law enforcement's time if that's the request? I don't think these are insurmountable, but I think the bill needs to address these kind of realities. The other problem is, or concern is that the law enforcement statewide use of force policy requires that any person who's in the care of custody of a police officer who sustains an injury or has an injury, whether or not it was caused by that police officer or not, the police officer has a duty to ensure that the person receives care. And so that's another reason why it would be, there's some conflicting and competing policies here. If an officer knows that a person's at a hospital, needs care, and is being asked to arrest and take that person away. Also, there is some anecdotal evidence from law enforcement officers that they've had difficulty in the past getting healthcare workers to give statements because of concerns about violating HIPAA. And so I think I think the committee needs to consider that as it's drafting this legislation. To kind of allay concerns about HIPAA and to make sure that officers would actually have probable cause to arrest somebody and they're able to obtain the kinds of statements they would need to make that arrest.
I appreciate that. I think that can be certainly written in as an HIPAA exception. I don't know if you have language from any other state. I'm sure every state is dealing with hospital violence at this point. So I don't think we're alone, but it has become, police are under-resourced, hospitals are under-resourced. And so it's something that I think we have to address, and we need to find a way to address it. But I think we can certainly find an exception to HIPAA that for many of these people were brought by law enforcement into the facility for treatment or for whatever, and the law enforcement has left, and this bill is suggesting that, allowing an arrest if this person assaults a healthcare worker or another patient or, whoever in the healthcare facility.
I don't think any of the problems are insurmountable. I just think they need to be addressed logistically, giving, the HIPAA, finding the exception in HIPAA that applies and maybe including that in the statute, making sure that people are not, that healthcare workers don't have an expectation that patients who have not been medically cleared are removed from the hospital. They have to be medically cleared to comply with EMTALA. making sure healthcare workers are not asking law enforcement officers to participate in the treatment by restraining people. I know there was a case here in Vermont where in this particular case, there was a psychiatric patient, and because the police officers were there or were called to be there, they were asked to participate in kind of restraining the patient, and the hospital, CMS determined that violated the patient's rights, and the hospital, kind of received a warning or some kind of write-up for that. So making sure that the lines are clear between what law enforcement is being asked to do, when they're being asked to do it, and also making sure that officers are not being asked to making sure that we understand where these patients are going to be going after if they're patients, after they're released, after they are arrested and taken from the hospital. We had a law enforcement officer talk about literally kind of driving in circles, because when they think somebody needs or is in need of detox because they've ingested many substances, they take them to the emergency department. The emergency department says, they can't do anything, they're cleared. So they take them to Act 1. Act 1 won't take them. They take them to jail. The jail won't take them because they still have drugs on board, and so they're back to the emergency department. And so we understand that oftentimes people engaging in violence are the people who are have consumed a lot of drugs, and so we want to make sure that the bill recognizes this situation where a person who's consumed a lot of drugs, who may have assaulted somebody in that state, who's kind of medically cleared to be taken away, but there's no place that will take them. And so just things to keep in mind as we work out a solution to address this problem.
It's a conundrum, but the hospitals can't continue to put up with this level of violence that they're seeing without some help. And I don't know how else to help them with it. The other issue, and is partly due to our mental health system not having placements available. Many of the people who become assaulted have been in the hospital for a long period of time because there is no other place for them. And and the hospital itself, I'm just speaking out from my experience with Southwest, is not really an appropriate place for long-term psychiatric care, because they're, for lack of a better term, isolated and almost in solitary confinement. And many of the rooms that they're placed in don't have windows. They don't have. It's really not a good situation, because these hospitals were designed to hold people for a few days, not for weeks. And so it's not surprising that some people act out in a violent manner. But I appreciate your concern. That if any of you have suggestions for changes to the bill, we'd be happy to look at them. Senator Sheen mentioned one possible, and I think Wilda mentioned an exception to HIPAA. I'm wondering if any of you could answer what the difference is with domestic violence. There's often no place to put them, but you at least can arrest them without a warrant. This bill is really almost the same as the domestic violence, removing the person from the situation.
I mean, I think the big difference, if it's a patient, is the patient is not, you want to make sure that the patient is medically stable. That's the
big all agree that if it's not the patient, then it's not an insurmountable problem. It's when it's a patient.
Yeah, when it's the patient, it's a problem. Or even if it's a family member who's been injured during the, even if it's not a patient, but say the violence led to an injury of the person who was creating the violence, then we have the same problem.
So if somebody, if I'm having a heart attack and I go to the emergency room and they can't see me because somebody's acting out, I should just expect to not get seen. Because somebody's acting out, we don't have a way to treat it. That's what the reality is. So if somebody else gets treated who's acting out or assaulting, it takes the whole, the doctor, the nurse, everything. That's the situation that many emergency rooms are facing. So when I've done nothing wrong, I'm just ill. I'm just using myself now as an example. So I don't get seen for 5 hours, I might die. But, because some idiot, and I'll use, idiot, forget the mental health patient now for a minute, but let's forget others, just some person acting out because he's angry or at the world today, cuts his finger and wants immediate attention at the emergency room. So he gets the attention of that, he gets everything else. In the meantime, a patient dies in the emergency room because they can't be seen because this jerk's acting out. That's the situation that I don't want to see happen in Vermont's emergency rooms.
And the Department of Public Safety and me personally, that I don't want to see that either. I just want to make sure that the problem that we're trying to solve will be actually solved by this bill. And I don't know that, the arrest is going to be a quick process. To ensure that somebody who's in acute distress is timely seen. This is it is a very difficult problem. And Department of Public Safety is not standing in the way of solution. We're trying to help with the solution. But we are also, there's some competing policies and practices here and some constraints of the law that I think we all want to be aware of so that we create a bill that has the most chance of being successful. Because timeliness, time is of the essence here. And it's not going to be a quick process.
Yeah, excuse me, Will, Senator Norris. So it appears everyone here wants to break the cycle of violence, whether it be in the hospitals, wherever that may be. And I believe I brought the point up earlier, and the deputy commissioner has brought it up also. So we have many beds that are being used throughout the state of Vermont. That's not the intent of them. For people who are waiting rooms, they've been through an evaluation, so on and so forth, but the beds aren't available. So I guess my question would be, if you have any suggestions, is so if law enforcement responds to one of these individuals who's really not in law enforcement custody, but simply awaiting a bed someplace, and they remove them to break the cycle of violence, what would you be expected of law enforcement to hold on to that individual for an indefinite period of time, and what facility do they have to do just that? So that appears to be a bit of a sticky wicket, shall we say. Maybe the colonel or the chief can jump in, I don't know. Did Will freeze up?
The chief.
Oh.
Senator Norris, I think we absolutely agree. And when we clearly the issue, and Ms. White brought it up, and the colonel brought it up, and Deputy Commissioner brought up as well, so I won't beat the point to death. But the issue of in the separation between who is a patient and who has not been treated, and for us to remove someone like that out of that situation obviously is the sticky wicket. We go back to Senator Sears, what you said kind of earlier about that these are not always the patients, that it's family members who are there who are insisting on treatment for their loved ones, or being the jerk. And I think the colonel mentioned it as well. We can deal with those, and we can deal with those currently. If this is a person who acted out in my own situation in the middle of Costco, and we go down there and we hand them a citation for their actions, that either threatening or assaultive behavior, and they're issued a trespass notice or removed from the building. Someone who is not expected to be seen for their health, I think we do have tools currently to be able to remove that person out of that setting.
If I may, Senator, I agree. I agree, Senator Norris, as well with the chief. And it is clear on those situations that are clearly not patients that we have the tools to manage that. It's people who are in medical care or seeking medical care that become problematic. And to your point, Senator, we have no training or ability to manage whatever medical condition that they're experiencing. And then we have no place to house them effectively. So those two challenges are for law enforcement are big challenges for us.
Thank you.
If there are any suggestions for changes to the bill besides those already mentioned, we'd be happy to hear them. If you could think of, I thought no trespass orders are you already do them, correct? For hospitals?
Senator, would take the hospital to make that request. The officer can do it. Statute allows us to do it on behalf of the person in control of the facility, but that request would have to come from the facility.
Absolutely. Okay. All right.
I think the last thing I didn't mention this, and I just want to throw it out. Unfortunately, it is another complication, but there's also policies about body-worn cameras and their use in hospitals. And I would ask the committee to solicit some testimony about whether that policy would be implicated by this. Currently, you're not supposed to use them unless there's use of force or a crime is imminent. But in a hospital, but I could see where these are very delicate situations, and I could see where someone might want to activate a body-worn camera in a hospital if it's involving the removal of a patient. So unfortunately, it's another complication, but I think it's something that the committee should deliberate about.
Okay.
Wilda, thank you for being here. Thank you everyone for being here. I'm looking at some of the HIPAA exemptions, and one of them says if you're concerned that a client might harm themselves or someone else. Do you feel like this might apply in the situation of needing an officer to stay if someone is violent?
I think you might be mixing apples and oranges. I don't know that HIPAA is about what information a healthcare worker can give to a third party about that patient. And when it comes to, giving a witness statement for, establishing probable cause, that's where HIPAA would arise. And so sometimes healthcare workers are reluctant to give these statements because some of the information that they may want to give, they receive is protected health information. And so HIPAA doesn't prohibit an officer from coming in to investigate. HIPAA, where HIPAA complicates it is what that healthcare worker can tell that officer to form the basis for probable cause. Because remember, these are non-witnessed incidents. Senator, have I responded to your question?
Yeah, well, that was my understanding of HIPAA as well, but then we heard testimony that officers can't stay because of HIPAA. So I was trying to understand the fine ins and outs of that as well, as I am not a lawyer.
Well, it would be the case that if the patient is actually being examined in an examination room, it would be the patient in that instance, if they were HIPAA might apply if the officer needed to stand by for safety reasons. That exception could come up. But when I mentioned HIPAA, I was talking more about establishing probable cause through witness statements.
Thank you.
Morning Fox and then Chief Allen.
Thank you. For the record, Morning Fox, Director of Mental Health Programs for the Department of Public Safety. To respond to the Senator's question around why law enforcement, 5 officers, they all left and no one remained in the emergency room. Part of the participation in CMS and CMS Medicaid and Medicare services, which is the primary funder for all of our hospitals, basically. The rules of participation are pretty clear that a hospital, once the custody, if you will, of an individual has been transferred to the hospital staff, then it's the hospital staff that has to, that is the only people that can engage physically with the patient. And so the request to have an officer remain, aside from the concerns around, short-staffed and needing to respond to other calls and calls of service and things of that sort, that officer would not be able to engage with that patient in a physical manner, say, to help restrain them so that they could be medicated or something of that sort. As Wilda White mentioned earlier, one of our hospitals in Vermont has already received kind of a warning from CMS for just that type of action. I'd be curious to know a bit more about the Southern Vermont Medical Center agreement with law enforcement to work within the confines of the hospital. My understanding is that would then require some sort of training within the hospital, and that they actually respond to hospital staff as directives, as opposed to, say, the sheriff in the moment. That it is possible, but it would have to be under a different guise, if you will, than we're acting as a sheriff or as a law enforcement officer.
Tom D at Southwest Medical Center would be more than happy to talk to you about how they're doing it, why they're doing it.
Yeah.
All I can tell you is what his testimony was last Wednesday.
And I admittedly, being out of the Department of Mental Health for the better part of the last year and a half or more, I'm a little bit out of those circles, so it's possible that things have changed.
My understanding is that you're correct about Medicare and Medicaid services, that the state is providing it. But if the hospital is able to contract, that doesn't violate that particular rule. It might violate something else that I don't know about, but at least that was, I asked Stephanie Barrett in my fiscal, I think it was Stephanie, but anyway, yes, Senator.
Yeah, no, and I certainly appreciate the importance of not having the officer engage physically unless, of course, it's reached a point where an arrest is going to be made, and that's certainly not what I'm suggesting. But there's plenty of instances where we deploy officers to keep the peace at protests and concerts and large outdoors. So I think there's a difference here between having an officer be present and having an officer engage physically with the patient. So I just want to make that clarification, that I'm certainly not suggesting that we shackle a patient to a bed. I'm suggesting that perhaps in an instance where tensions are high, an officer's presence might help keep the peace.
Chief, did you have anything to add?
Mr. Fox gave most of the information that I was going to share. My department was actually part of the write-up that UVM MC got. And they were in the ER on another matter. A disturbance happened with a patient. They intervened. They actually de-escalated the situation verbally, and they got a level of trust with the patient, and rolled him back to his room and helped him get back onto a stretcher or a cot, and that was shown to be a violation. So I think you're right, Senator, that if there is an active threat or an active assault, and what we were told also is that if we have someone in custody, that custody remains. We remain with the patient until they are treated and released or whatever occurs. But once that transfer is made, or if they're already in the care of the facility, law enforcement needs to really stay away.
I know it's been brought up, but could you just remind me again what the violation is, under what statute, or is it state or federal?
What they quoted to me was that it was federal. Morning Fox, maybe you have a better handle on that.
It's part of the CMS rules of participation for hospitals. Mhm.
I will get you this specific rule, statute, and probably some examples of where it's been violated.
Well, yeah, thank you, I appreciate that. And I don't, who should we look to for something on the body cameras? Is that policy or is that law or is it?
There's a statewide body camera policy. Maybe we will get back to you on that as well.
Is it any different than your house has been broken into and there's sensitive art that they didn't take and we don't film it? I remember that discussion when we were doing the body camera bills years ago.
Yeah, just a quick question, Chief or Colonel. The Defender General's office and the ACLU has chimed in and said that we currently have laws on the books that already take care of this problem. Do you see that this bill would address anything further, or do you agree with that?
I agree that we have laws on the books to handle the clear-cut cases of a non-patient committing a crime in a hospital. I think trying to apply those same laws to patients is much more complicated.
And I would agree that there already is an exception in Vermont Rules of Criminal Procedure, what we call Rule 3, that would allow for a simple assault perpetrator to be taken into custody without it being witnessed. I think a change would be, I think if I'm correct, the bill also calls for criminal threatening and disorderly conduct. That would be a change.
I mean, I want to protect all of our healthcare workers, be it as it may. Obviously, I have friends that work in the health system also, but is this just a duplication of the laws that we presently have on the books? Is my question, I guess.
It's not a duplication. There is some overlap.
Such as, can you just give me a quick overview?
Well, I think the chief just gave you one. So this bill expands it to criminal threatening and disorderly conduct for non-witness misdemeanor arrest. That's new.
Okay, thank you.
Is there any questions or comments from the Department of Public Safety? Thank you all very much. And if you have any suggested changes, if you get them to myself and Eric, it'd be appreciated. Eric Fitzpatrick, who's on Zoom with us today.
Thank you.
Thank you. Thank you. Thank you. Our next witness is Jim Finger, President of Vermont Excuse me, I just popped in my mask. President of the Vermont Ambulance Association.
Good morning. I am Jim Finger, President of the Vermont Ambulance Association. I thank you for including EMS in this discussion. I will tell you that workplace violence and/or the patients included is problematic, and we're all understaffed, including the police, hospital, and EMS. This is just one more complication that's included in it, and we appreciate you for working with us. We also work very closely with the hospitals and the police all the time with these situations, and we work together as a team. A couple things looking at the bill that I would ask you to look at is your definitions that you have of healthcare worker. I don't know what the state definition of a healthcare worker, but I would appreciate if you would look in and include EMS, because the EMS not only works in the hospital, but transfers the patients from facility to facility, and including mental health, and it's all make sure that EMS is part of the definitions. The other thing that you have in there is healthcare facility. Would like you to check on that as well. What I see under our rules and is I think a healthcare facility is just a hospital, and that may be just the intent of the bill. But
I think it actually would cover nursing homes, doctors' practices. As one of the sponsors, I would say that one of the intent was to cover EMS, but I'm not sure it does. We'll make sure it does.
I thank you. And I only brought healthcare facility because it says specifically in ours.
It was a broad brush of healthcare facility term, what our intent was.
Thank you. And we really appreciate you taking us into consideration and look at this, and we're happy to help in any way that we can.
You heard some of the concerns. You're like the first responders out there in the community. Are your members getting assaulted on a regular basis? Is it a problem, or is it isolated?
No, it's problematic now that it's even getting worse. And you've heard from the hospitals, and I've read the articles and talked to our hospital staff, even locally. It's problematic now. There's a lot of things that got worse since HIPAA, and this is one of them. And it's also creating more problems for us to retain and recruit staff. So it is important that you include us, and it's important that you address it.
Questions for Mr. Finger?
Yeah.
Yes.
Mr. Finger, thank you for being here. My question, I'm trying to figure out how to phrase it in my head here, but one of the concerns that we've heard a lot about and that I agree with is the difference between somebody who's going through a mental health situation versus somebody who's intentionally choosing to be violent and destructive in an ER or towards healthcare workers. And and so I'm wondering, do EMS workers, before they call the police, have protocols in place when it comes to dealing with mental health situations to help make that determination, or not the determination, but the differentiation between somebody who's choosing to act out violently versus somebody who's going through a mental health episode? I don't know if I articulated that very well, but.
No, I would answer your question, and I think Drew would maybe be able to answer this one a little better from the rules and the field perspective. But it's problematic for our staff. For example, we go between hospitals transferring them, and if they're involuntary, we actually have to let them go and get out of the ambulance. So, and we would let them, especially in this case, we'd call the police and then say, patient has left, patient may be dangerous, whichever. But healthcare, as far as rules, the training we have is minimal. I would say that we do deal with it, and training there are so many areas to train that it's very difficult. But it's an issue that does come up now all the time, more than ever. And I would ask this again of Drew.
Thank you.
Any other questions? Thanks so much for being with us today.
Thank you, sir.
Our next witness is Drew Hazelton, Vice President and Chair of the Emergency Medical Services Advisory Board.
Good morning. Can you hear me? So again, like Jim, thank you for inviting us, including us in this discussion. Certainly, workplace violence is a concern. Just like our hospital counterparts, we're seeing an increase in violence towards our providers, not only in the field, but as we're turning patients over at the hospital, and certainly at times while we're moving patients between facilities. My read through the bill, my first thought was, do we already have laws that are designed to help protect EMS professionals, which we do under 13 VSA 1028. We're listed as part of the protected professionals. One of our challenges that we've had in our area is that we're unable to get people that have assaulted our staff actually charged, despite a willingness to provide those statements. And under HIPAA, we can disclose and report information as it pertains to crime. That is one of the exceptions. So if you assault a staff member, whether it is a patient or a family member, the information needed for law enforcement to prosecute the crime is exempt from HIPAA. So that should not be a barrier. But what we are running into is that we can't actually see and get follow through on the law that currently exists. So that was the first thing when I kind of read through this that I see. And then the second thing that I certainly am sympathetic about the staffing changes in law enforcement. And we see it regularly where we're put into challenging situations because of law enforcement, either through lack of available police officers or through the new policies that are unwilling to respond to potentially violent scenes. So what we're noticing now, for example, I had a crew that was stuck waiting 2.5 hours for state police last week at a violent scene. And what we're seeing is because of these delays and because of the lack of law enforcement response, EMS crews are getting put into more complicated and dangerous situations. So the number and likelihood of assault, because we're going into what I would call, sketchier situations without law enforcement being present. So I do appreciate the committee looking at how to discourage assault on healthcare workers. At the same time, I know we do have laws in place that we could probably do a better job enforcing.
Drew, it's good to see you. Thank you for testifying here. One of my questions, going back to your earlier point about the unwillingness to charge and the lack of follow through from law enforcement, from what you've seen, do you feel that this is due to a lack of clarity in Rule 3, which this bill is trying to address, or do you feel like it's a staffing issue, or maybe a combination of all those things, just based on your experiences?
I think it's probably a combination of things. And, most of these patients, the assault that we're looking to get prosecuted has nothing to do with removing them from the facility. It's even after the fact or after the incident, saying no follow-up. I look at if the assault had been on a law enforcement officer, and, we deal with these when law enforcement gets assaulted. Quite often we're involved in the case. If it was an assault on a law enforcement officer, that person would be taken into custody. They would go to the hospital. Law enforcement would stay with them, and they would, be charged. That doesn't seem to be consistent across the board when it's an assault on a healthcare worker. It seems to be there's a difference in that level of response and willingness to follow through with prosecution.
Thanks, Drew.
Drew, what part of the state are you from?
The southeastern corner.
Oh, okay. That's a nice area for the state.
It's a very nice area.
I'm able to visit there once in a while if I can get over Route 9. Can't get to Burlington.
Right.
Another nice area.
Yeah.
Yes.
Well, I haven't been there in years. Thank you very much. I really don't have any questions for you, but I thank you for being here. Are there any other questions for Drew? Okay, great. Our next witness just arrived, Meg Foley. Nice to see you again.
It's the hot seat.
The hot seat, or whatever you want to call it.
This is my first time in your committee.
Well, yes.
Not first time in the building.
Not my first
Not
time
first
in the
time in the
building.
building.
No, not at all.
You know everybody.
Don't.
Bob Norris, Franklin County.
Nice to meet you. Welcome to the building.
Tony Pilowski, Chittenden Central.
Dick Sears, Bennington County.
Not a machine when we can.
I'm Phil Bruce, Chittenden Central.
My very own.
Chittenden Central. Sounds funny, really does. But
Yeah.
it's gonna take a while to get.
Still sounds
to
funny.
Central.
It's not central, it's north.
But we already have a ship in North.
I know. All right, are you ready for me?
Yes,
All
please.
righty, so my name's Meg Polite. I'm the policy director for the Vermont chapter of the Alzheimer's Association. And I'm here to share my thoughts and concerns on S36 and the impact arrest without warrant would have on Vermonters with Alzheimer's and other dementias. So I've listened to the deeply disturbing testimony actually that was shared last week, and I fully support protecting our frontline workers and addressing their safety needs in a way that will not cause unintended harm. There are currently over 6 million Americans over the age of 65 who've been diagnosed with Alzheimer's or another dementia. This includes 13,000 Vermonters, a number we expect to grow by over 13% to 17,000 in the next 2 years, 30% to 17,000. This number doesn't reflect the whole picture as it does not count those who do not have a diagnosis, have been misdiagnosed, and more relevant to this conversation, those with younger onset Alzheimer's, meaning they were diagnosed under the age of 65. And I highlight this group just to emphasize the need to broaden our awareness of the demographic that can be experiencing dementia. Dementia is the general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life, and Alzheimer's is the most common form of dementia. The symptoms vary from person to person and by type, but typically include memory loss and confusion, poor judgment, difficulty communicating with and understanding others, wandering and getting lost in familiar places, mishandling of money and finances, impulsivity, aggression, hallucinating or experiencing paranoia or delusion, and repeating questions. Individuals with dementia may exhibit behavioral problems that cause safety concerns and warrant police involvement. Cognitive and sensory impairment, confusion, challenges with speaking, and other factors may result in escalated police involvement during crisis, and police are often not properly trained to identify and address these health-related issues. The timely identification of dementia is essential to understanding a person's behaviors. So last year, the House Committee on Human Services took some testimony on H530, which was an act related to creating a silver alert program to address older Vermonters that wander or leave their residence and how to safely recover them. And as a result of that, our program manager of the Vermont chapter and I have been working with the Department of Public Safety to identify appropriate training focused on recognizing the signs of dementia and communicating with people with dementia that they will hopefully add to the law enforcement requirements for the state police. And trainings like these would provide public safety officers and also emergency room personnel additional tools for interactions and also for identifying people with dementia. We are really aware of an increased number of people with dementia being brought to the emergency room, in part due to our workforce crisis, and in part due to insufficient residential capacity for Vermonters with dementia. So for instance, at Allenbrook and Williston, which is our only affordable memory care unit, there's 14, they call them homes, they're beds, and there's 100 people on the wait list to get in there right now. Long-term care facilities are often not equipped to support those with dementia, especially who exhibit behavioral issues. And involuntary discharge was the Vermont Ombudsman's project's most common complaint in fiscal year 2022. So over 12% of all their complaints last year were due to involuntary discharges. And when you consider the wide breadth of issues that they work on there and how serious involuntary discharge is, I think this is a shockingly high number.
I'm sorry, I don't understand it. Well, I do understand, I think, but describe exactly what involuntary discharge.
So involuntary discharge means that they're asked to, or required to leave the facility, and they're
because their behavior is beyond.
Generally, the reason is because the facility cannot deal with their behavior. They're not equipped to safely deal with their behavior and keep their residents and their staff safe in that situation. So it's a pretty high number. And we know that there's 50 to 70.
What is the requirement for that facility when they involuntarily discharge them? There's no requirement on them by the state?
Not that I'm aware of. Not that I'm aware of, and we definitely have worked with advocates whose parents faced that, where the facility couldn't keep them safely and they ended up in the emergency room and waiting in the hospital until they could find a placement. And the case I'm familiar with, the placement wasn't even in Vermont, it was in New York, because there were no placements in Vermont that could accept somebody with those behavioral issues. So, in November, Dr. Stephen Leffler, the president of UVM-MC, told VPR in an article looking at older people who were stuck in the hospital that they have 50 to 70 beds taken by people who don't need hospital care and can't need. Not all have dementia, but a large percentage of those are due to dementia or behavioral issues. There's just nowhere for them to send them. We know hospital emergency rooms, 4 beds can be very challenging for a person with dementia, and acting out may be their response to confusion by the situation. And that's why S36 is so concerning to me. I understand from previous testimony that this bill is not aimed at people with dementia, but I'm concerned about the implications it can have on them. So just to give you an example, like a person with dementia could be unintentionally arrested or charged in a situation that's very common, which is that they have urinary tract infections or other minor infections. They go to the emergency room. If you don't have dementia, you can explain what's going on, you can help in the diagnosis, you get your medication and you leave. But for someone with dementia, due to their loss of cognitive function, they're unable to aid in their diagnosis because they can't articulate or even identify the cause of their physical discomfort, and therefore they could easily express it through physical aggression towards their healthcare worker. So what I'm asking is that you explicitly carve out an exception in this for people living with dementia, and that you're careful when you consider how those with dementia will be identified and protected, because it's quite possible that someone who's yet to be diagnosed could find themselves in an emergency room, confused, triggered by the environment. So requiring a previous diagnosis is probably not going to be sufficient nor capture the full scope of people. Vermont is not the only state working to address violence against frontline healthcare workers, and I don't believe it's the intention of this bill to charge those with dementia. But unfortunately, we have our first evidence that those with dementia do get caught in these systems. In 2022, as part of a research project, South Carolina compared data from a statewide database on dementia with a statewide criminal database, and there were 214 responses, 17 of which, so almost 8%, were people living with dementia were charged or convicted of assault on a healthcare worker in a healthcare setting or skilled nursing facility, and I linked to that research. So this is the first and strongest evidence that we've seen that despite the intentions of states, people with dementia are still being charged and potentially convicted in these crimes. And for more information on the challenges of those with dementia in the criminal justice system, I linked in the full report, which was done by the American Bar Association on folks with dementia and how they move through the criminal justice system. Thank you for your time and consideration for those with dementia in Vermont, and I look forward to working with you.
Senator Brewer.
Thank you, Meg. I appreciate it. I'm wondering, the bill is really centered around allowing warrantless arrest rather than charging decisions. And I heard you speaking to hoping that we could carve out that they wouldn't be charged. Are you also asking that they not be arrested without a warrant? And I see you nodding. So then my question would be, if there's no previous diagnosis and they are unable to communicate their situation, how would that work in real time if, let's say, a person has exhibited aggressive behavior, they've crossed the lines that we've been talking about? How would the frontline staff there render a diagnosis of dementia and then not do the warrant? How would that work out?
Yeah, so to be clear, I'm asking that they would not be arrested at all, that it would be identified that they're a person with dementia, they would be brought into a situation where they could de-escalate and receive the treatment that they need. I think in the majority of cases, if not all cases, they're not going to be coming in on their own when they're in that stage. So they're going to be with a family member, spouse, or somebody who's probably going to say, my husband, daughter, partner, wife, whatever, has some form of dementia or is experiencing signs of dementia or is often confused. They may also not know. And that's why these trainings around like understanding what are the signs of dementia versus the signs of someone who might be having a mental health crisis or reacting to lack of or substance abuse are really important The typical responses of sort of being louder and being repetitive for somebody who's already been triggered and their communication is shutting down is going to just escalate their frustration of trying to communicate and escalate the chances that they're going to, push somebody away, refuse treatment, become belligerent, et cetera. And I think that the report from May really had some interesting case studies of like what happens then. Like if you do arrest them, what I understood is like when someone's not acting out, you try and bring them to a stage, whether it's through a facility or through space somewhere where they come so that they can communicate and they can understand what's going on, and then you move forward. But with people with dementia, that's often not going to ever be possible. You can't rectify that situation because they have a cognitive issue that's not allowing for that.
Yeah, and I see the thrust of what you're saying and the desire for it, and I agree. I guess I'm just wondering, in terms of if there's a family member there who could communicate the diagnosis, then it seems pretty clear that that there would be an easy enough way to, well, I don't want to say it's easy, but at least there's a clear path to treating this person differently. If the person is there without a family member or without somebody to communicate the diagnosis, it's not perfectly clear to me how we would differentiate between someone else in mental health crisis from that person if the people at the ER aren't skilled in determining. And that goes to your point about education.
And I will just say, Senator Ruth, they're often separated from their family members. There's often a degree of shame and not wanting to express what's going on. So the family member may know, but they may be in a room, getting treated on their own where that connection isn't being made. It could be both people in the family are in denial about what's going on and have not wanted to proceed with a diagnosis. And it's at the stage of, again, aggression, behavioral issues, hallucinations, which can be very real. So there really are numerous stories of situations where this just isn't going to work, and I can't pretend to be the person that can figure out how this would be written into a law. I just want to be really clear that we know this is happening. I've heard situations of people going to the emergency room, and I want you to be aware of what it could look like. And I know it's very different than where the bill started from, but it could easily be.
Well, I'll just give you a quick story of my own. My mother spent 5 months in Fletcher Allen, dying of cancer. And during that time, we were in the emergency room, and there was a woman who had broken her ankle at a memory care facility in Shelburne, and she had been brought to the emergency room. She had no idea that the person who was with her was her son. And so she claimed not to know him. They understood from his identification and other things that he was her son and communicating with the memory care facility. But she was, in pain. She was also upset because strangers were doing these things to her, taking her places. And so she was really loud for a couple of hours while we were next to her in the emergency room. She wasn't aggressive in terms of physically assaulting people, but I could see how had she been a younger person, a stronger person, that might have been an issue as well. So I'm very sympathetic to what you're saying. I'm just trying to figure out in terms of this bill, because we've been dealing with radically understaffed facilities, 2 people on watch and an aggressive person striking them, physically assaulting them. And so at that point, to ask them to be diagnosing on the fly dementia it's an ideal, but I'm just not sure how practically we would be calling for that.
Well, it's a catch-22. There was a case several years ago, I scratched my head. It was an 85-year-old man had thrown an ashtray at his wife probably 60 years, and he was charged with domestic violence. And I'm saying, well, probably dementia was part of this aggression. I have knowledge of that, but it's, so, he does something, he gets charged with domestic violence. Criminal justice system has to deal with it, but it's really probably a dementia or other aging problem. But then, they get into aggressive behavior, they burn out staff at a nursing home, so there's no staff at the nursing home to take care of people. And then they burn out staff in the emergency room because there's no emergency room people to take care of. And then all the situations burn out law enforcement. And, we're back in this vicious cycle that we have to break. I don't know how to make a carve out for dementia any more than I would know how to make a carve out on domestic violence laws and others. Asking maybe that the criminal justice system recognize when somebody's incompetent. So I think at that point they might have been charged, but they're not going to get convicted. I guess I'm just speculating about this man, but you get charged with domestic violence. It's a cycle, and I feel as a legislator some responsibility to try to deal with this problem in our healthcare facilities. If this isn't the solution, and all of you listening in, I'd like to know what is. Because it's easy to pick apart a proposal. Then again, to come up with something that will help. And I thought that the comparison for domestic violence, that's basically what we've done with domestic violence, is rewrite Rule 3, or make an exception to 3, arrest without having the officer visibly see the assault.
I actually had a question for Eric Fitzpatrick, and I'm curious if you could talk about the mental element for these crimes, and if somebody is charged, when does that, where's that threshold for when the intent no longer exists if they are either dealing with dementia or any other mental health issue?
Well, if I'm understanding your question correctly, are you asking about sort of when the defendant's mental health status would sort of be relevant to whether or not they had committed a crime? Is that kind of what we're getting at, or?
Yeah. That sounds about right.
Yeah, right. Well, I think that if you got two separate issues, because you have competency and sanity at the time of the offense are the two sort of legal issues that are involved with whether or not a person can be charged with a crime based on their mental health status. So it sounds like in a case like this, you're talking about if someone was potentially arrested for a criminal offense, if their mental health at the time of that arrest was such that they could not appreciate the nature of their conduct, or they could not conform their conduct to the requirements of the law. For whatever reason that was, they could not be charged with the offense. That's an insanity defense, which is a complete defense, and they could not be convicted of it. So they couldn't be charged again with it either, as opposed to a competency piece. That analysis of competency goes to the defendant's mental health status at the time of the proceedings. So those are the two different time periods we're talking about. The insanity defense goes to the mental health status at the time of the alleged crime. And the person has to be able to either conform their conduct to the requirements of the law or understand that what they're doing is illegal. And if they can't do either one of those things, whether it's because of dementia or any other mental health issue, then it's a complete defense. So again, this is separate from the issue of arrest. This is the criminal charge. And then even if someone were sane at the time that they committed the offense, they could still be incompetent to stand trial. And if that depends on whether or not a person can understand the nature of the proceedings against them, or what they call participate meaningfully in their own defense. So even if you were sane when the alleged offense happened, if you were not able to understand the nature of the criminal proceedings, or you couldn't assist your attorney you couldn't be charged. You'd be deemed incompetent to stand trial, and you could not be charged with it until such time as you regained competency sometime in the future. If you did, if you didn't, then you could never be charged. Does that help or kind of get at what you were asking?
It does. I mean, I was curious about, downstream, after an arrest is made, and if it does turn out to be somebody who has a mental health issue, how it works out in the courts after they've been arrested. So thank you.
Sure.
Thanks, Eric.
You bet.
Yeah, I'll just to follow up, I think, a couple things are like looking in the emergency room at when you're calling in a crisis worker, when you're calling in a specialist to make a tentative diagnosis. So Senator Ruth, you mentioned make a diagnosis, like it just doesn't happen like that. There wouldn't be a case where they'd be making the diagnosis in the emergency room. And then thinking back to like, how do we avoid this? I think there's a lot of work being done around patient-centered care and the environments that we're putting people in, and the way to avoid a lot of this, not all of it, because there are certain forms of dementia that really can impact aggression and hallucinations a lot, but for a vast number of people, it's very situational. So again, it's just being in a situation that's so unfamiliar, whether that's your long-term care facility that tweaks you and you get involuntarily discharged and end up in the emergency room. So looking at, what can be done to kind of put a stop in there and create a space for the person to come back and settle down enough so that they can at least frame where they're at and what is going on. And it would encourage anyone who's interested to look at the final link, because it specifically talks about what happened to people that were actually arrested as they tried to go through the criminal system, and in South Carolina, at least, the different options. The summary is not, it's not a lot of pages, but it was it addressed some of the questions you raised, Senator Shim, about what happens afterward and what are your choices. And it does address also domestic violence in that study, because there was a significant number in that area as well.
Other questions from Mike? Thank you very much.
I'm available if I can be of further assistance to you, and I appreciate your time and the attention you're paying to this bill and how you're solving the challenges. So thank you very much for having me in.
Eric, do you want to join us remotely? Please. One issue is the exemption from HIPAA. Any exemptions from HIPAA? And I know you've got some experience in writing exemptions to HIPAA.
Yes. If I could, Senator Sears, I'd like to make an observation about what this bill does and what it doesn't do. There's been a lot of discussion of possible exemptions for HIPAA, of possible application of portions of the Medicaid law, which may limit what a hospital can permit to have happen on the facility, other federal law that may limit what law enforcement can do when they're in the facility. And I certainly will look at this a little bit more. But I want to remind the committee that all this bill does is propose to add a couple of non-witnessed misdemeanor offenses to an existing list of misdemeanor offenses for which law enforcement can conduct an arrest without a warrant. It does not require a hospital or any other healthcare facility to call law enforcement to ask them to come arrest somebody. In my view, whether or not those other federal laws are being violated is not addressed in this bill. That is up to a healthcare facility. If they think that it's going to be a violation of a separate federal law which applies to them, that it will be a violation of that law for them to have law enforcement come in and arrest somebody, then they need not make the call. If they think that it's going to possibly implicate their liability under these other federal statutes, then they are not required by this bill. Sorry, that was just a funny sound. They're not required to call law enforcement in and ask for an arrest. They can make that judgment right there. For example, we're talking about whether, a lot of discussion about whether someone can be removed from the hospital setting when they are not stabilized as a patient. Again, that's not addressed in this bill. That's not an issue of whether or not a law enforcement officer has legal authority to make a non-witnessed misdemeanor arrest, which already exists. Remember, it's interesting, some of these offenses, if they were felonies, which, you know, because all felonies, whether witnessed or unwitnessed, under existing law, the law enforcement officer can make an arrest, whether the crime was witnessed or unwitnessed. That's existing. So if the assault, for example, was a felony level assault, then they could do this under existing law as it is. As one of your witnesses testified this morning, there is some overlap between these two bills. So even a misdemeanor assault, a misdemeanor non-witnessed assault, under the existing rule, law enforcement can make that arrest as it is, even without the proposed change. So if a misdemeanor assault happened right now in a hospital, any healthcare facility, the officer could, and the officer was not there to witness it. There were other witnesses in the hospital who were there, and they saw it, and they decided they want to call law enforcement and ask them to make this arrest. They have the authority to do that under the existing rule. So any concerns that have been discussed regarding whether or not that might implicate the healthcare facility's federal legal obligations already exist. The proposed new offenses for criminal threatening and disturbing the peace are simply two more iterations of the exact same pattern that exists now. So I just wanted to remind the committee of that. And you know, to the extent that you think that any exceptions are necessary, which I'm not sure I do, in terms of this rule, I would suggest that they would be added in a separate piece of the bill. You don't want to add that to Rule 3 of the Vermont Rules of Criminal Procedure, which is simply a list of what offenses an officer can make an arrest for, with or without, or whether they've witnessed it or not. So just wanted to lay that down as a background. And I'll pause there in case anybody wanted to ask anything.
It's very helpful there.
I just wanted to voice, I think, I mean, I empathize a lot with the concerns about dementia and Alzheimer's and making a carve out, but I just think that making a carve out could pose some challenges, because then we have to start taking into consideration other mental health issues. What about schizophrenia? What about bipolar disorder? There's a lot of things, and so that when we open up that door, you know, how do we end up working through that? So that's just a concern that's in my head about this.
But I am concerned about the HIPAA requirement.
I don't see, I have a hard time seeing how HIPAA comes into play here. I mean, it's a bill that's allowing for a warrantless arrest without any information other than the testimony of what's happened.
Well, I think part of it is the concern from healthcare workers that providing testimony about their assault or what they're seeing in the ER could violate HIPAA. But then we all.
But HIPAA doesn't protect criminal behavior. Like, right. You know, there's a carve out in HIPAA for that. So yeah. I'm, you know, if someone is in the ER and they assault the nurse and the nurse testifies to that to the officer and he arrests without a warrant, I can't see how HIPAA comes into play in any.
We probably should ask, I think Health and Welfare is going to take a look at the bill.
Okay.
After we finish it, so they could probably look at that as you're probably right.
And I think that we've addressed it briefly, is if in fact the hospitals do call and law enforcement does respond, I want to break the cycle, clearly. But if it's someone who is there awaiting a bed, and now they're in law enforcement's custody, that's kind of a two-pronged thing where now what do they do with these individuals who need specialized services, which they're not going to be able to provide, obviously. So what happens on that end of the spectrum?
This is a problem that's not isolated to hospitals, unfortunately. It's everywhere. All of our systems of care are dependent on availability of resources. And then when those resources are not available, it falls on to probably the least prepared. The emergency room has to take people. Police have to respond. I know the program I used to run is suffering because there's no Woodside. And so kids who are out of control are awaiting a bed in a short-term program that probably wasn't designed for them. And they wait that bed for 60 days in a program that was designed for 10, and they're in trouble. And that creates further problems. I think, truly have a resource problem in the state in terms of nationally as well. Do you want to comment on that, or is it different?
I have a different question. I mean, I certainly agree that this is not limited to hospitals. It's not even just limited to our system of care. I think it's a larger breakdown of community, but that is a different conversation. My question is actually for Eric, and if you can give me a legal definition of disorderly conduct. What does that entail? Because I have concerns with that part of the bill and the impact that it might have on people even seeking care if they're worried that their behavior may, if they're really struggling and they're like, well, I'm not even gonna go to the hospital because I might get arrested.
Yes, and I'll turn to that in a moment, if you wouldn't mind, Senator Bahovsky, just because I want to answer a question that you and other members of the committee just had a few minutes ago that I didn't get a chance to answer, and that is specific to HIPAA. So there is a HIPAA exemption. I just pulled it up. So HIPAA generally applies when a covered entity limits their disclosure of what's known as PHI, protected healthcare information. However, HIPAA contains a long list of exemptions, and one of the exemptions is for law enforcement purposes. Has a lengthy list of law enforcement purposes that are exempt, including to identify or locate a suspect, fugitive, material witness, or missing person. To alert when a covered entity believes that protected health information is evidence of a crime that occurred on its premises, which seems directly relevant. Covered by a healthcare provider in a medical emergency occurring on its premises when necessary to inform law enforcement about the commission and nature of a crime, the location of the crime or crime victims, or the perpetrator of the crime. So it seems to me it's right on point that you've got an exemption right in HIPAA. That now again, that's understand that is to give the committee comfort that the legislation doesn't necessarily implicate HIPAA. In terms of who it is that has to decide, on the ground, whether or not I should answer this question or disclose this information, that's the healthcare person. That's not something for that the legislature can put in law, although there is separately another exemption for required legal disclosures, but that's a separate issue. But the point is that to the extent that a healthcare worker is concerned that talking to a law enforcement officer about a crime that had occurred on the premises might violate their responsibilities under HIPAA, there's an exemption right there that I just described that should alleviate that concern. Does that make sense?
Thank you.
Yeah. Now, sorry to interrupt, Senator Bahovsky, but to come back to your question there, and the disturbing the peace is a somewhat elastic concept for sure. I'm just pulling up the statute because I want to be able to read you the language from the statute rather than try and remember it myself verbatim, which I'm certain I would not do.
Just, so the language in the bill is around disorderly conduct.
Oh, I'm sorry.
I struggle to make the differentiation between disorderly conduct versus disturbing the peace. So there's a whole other piece here.
Yes, I'm sorry, I misspoke. I meant disorderly conduct. So yes, the disorderly conduct statute, I'll read to you. A person is guilty of disorderly conduct if he or she, with intent to cause public inconvenience or annoyance, or recklessly creating a risk thereof, engages in fighting or in violent, tumultuous, or threatening behavior, makes unreasonable noise, in a public place uses abusive or obscene language, without lawful authority disturbs any lawful assembly or meeting of persons, or obstructs vehicular or pedestrian traffic. So I think the courts have at times with statutes like this, there's has been concern about whether, for example, protected First Amendment activity is being infringed upon by a disorderly conduct statute. So the courts interpret these two sorts of statutes to apply to someone's constitutional rights. So what I just read would have to be sort of looked at through that lens, that if it's something that's some behavior that's constitutionally protected, then this statute wouldn't apply. But what I just described is sort of the general types of conduct. And in case you want to look at it, well, you probably have it in the bill, but it's 13 VSA 1026 1026. But,
thank you.
Yep.
Well, other questions for Eric? Simple little bit. It was.
Those are usually the ones that go off the rails the quickest.
Well, I think as Eric has pointed out, it simply gives authority. I think questions about whether disorderly conduct should be part of the bill are certainly subject for conversation, but certainly when we get to the point of assault or criminal threatening, the threat to, that one of the nurses described about her home, I'm going to get you and your family, I'm going to, I know where you live, blah, blah, blah. That sort of behavior, certainly, we could have a debate whether we want to keep the disorderly conduct.
Yeah, I was just going to mention, I agree with the disorderly conduct bit, that it's right for discussion, but I think it's also good to remember that we have the line that says, disorderly conduct that interfered with the provision of medically necessary healthcare services in a healthcare facility. And, that I think helps make that differentiation between someone being obnoxious in the waiting room versus somebody throwing chairs, going into other patients' rooms and disrupting care. And then on another topic, I think it may be worthwhile to discuss putting in a provision related to whether or not that patient has been medically cleared and stabilized. If the officer makes the decision to arrest, certainly nobody wants that liability. And I think including that provision would be helpful and hopefully alleviate some of the concerns voiced by TPS.
Is that medically to include psychiatric care?
It's a great question. Something worth talking about.
Okay.
I mean, is there ever, for some mental health situations, though, is there ever really a stabilized nature to it?
I'd like to a lot of medical professionals.
Yeah, no, just a
I'd like to
rhetorical question.
experiences where I don't know the patients at all. It was, working with the Department of Mental Health in one case, and I think DCF, how to get somebody out of the emergency room. And the lack of beds was the problem. But the behavior from the person was assaultive in the hospital in both cases. I was trying to intercede on behalf of the lawyers and others with the departments. And that's what's difficult, is getting them, you know, so we put in medically cleared and we're still back to square one, but at least for the, I don't know how to write that medically cleared, Eric. So if the guy's got a broken leg and they put a cast on him and he's still abusive, I suppose they've cleared and they've done what they're supposed to do.
You can still commit domestic assault, simple assault with a cast on.
Yeah.
Well, I see the intent there, but it seems like if we go back to that testimony, these are people that they were having a hard time doing anything with. So if we require them to medically clear them, it seems like they're looking for a way to get the person out. And they're looking at it as a priority one thing because it's taking care from other people. It seems like then we push them to clear somebody just to get rid of them. So I go back to the extremely limited nature of this bill. It's basically just saying we'll allow what would happen if the police had observed it without them observing it. So I don't think the bill's taking on the responsibility to do what wouldn't have been done had the officer witnessed it. So if the officer had witnessed it, we wouldn't ask that they be cleared or stabilized.
Right.
They would then remove them. So I think if we take on that responsibility in this bill, in order to add these three things to the warrantless list, we have to put on healthcare workers stabilization and clearing. We're kind of defeating the purpose of the bill, which is in that extreme instance to allow them to forgo that observation by the officer. So that's I guess what I'm saying is the bill is doing very little to help, but if we add those conditions, it won't even be able to help in that way, really, because they won't be able to clear and stabilize the individuals we've been talking about.
I think it could, I see your point, I hadn't thought of that, I think it could be reworded. If somebody has initiated medical care, you know, they come in peacefully, it's triaged, screened, put into a room, and then suddenly they decide to start fighting, then maybe the medically cleared determination can be made. But if somebody walks into the ER or is a visitor or a guest, and maybe a family member of somebody is there and they decide to start fighting or being disorderly, then they wouldn't have to be medically cleared.
But I guess what I'm saying is we're not requiring that if the officer saw the activity. This bill would require clearing and stabilization of that. So we're, in this case, by just eliminating the officer seeing the event, we're adding burdens onto the healthcare workers to testify to clearing and stabilization. And if they can't stabilize them, we're not going to let this go into effect.
I think we're.
Yeah. I mean, my understanding is there's already federal law that requires stabilization and medical clearance, that we are simply repeating what is already under, I believe it was the Emergency Medical Care and Active Labor Act. So, and we heard testimony from the police that they're not going to take someone who they're then assuming liability for if they're worried they're not cleared. So I think that to your point, we do require that already. It's just under federal law, not state law. And I see people shaking their heads.
No, I'm comfortable with where we're getting into. And I think that creating, I mean, it's always a judgment call, but what the police officer does once they're called, they may, I mean, I've seen situations where just the police officer being there de-escalates immediately the situation.
Yeah.
And I've seen situations where it's actually escalated.
Yes.
So it can work both ways, you know? But I think it's really judgment. I'm not really worried. I think you made some good points, Senator. That's where we're really at. We have this scheduled for Thursday, and so we can think about it until then. And Eric, if you can just, if there's any suggestions, come in. I think Mike Fisher would like to testify for the care. But he may want to testify in health welfare. So.
Should we also hear from, I don't know if we have it scheduled, but folks who, not healthcare providers, but hospital staff, administrative staff, who are the ones that deal with rules and regulations and the protocols that are in place for determining, when you call the police if somebody's acting out in an emergency room, for example. I think that would be helpful.
Didn't Tom D talked about it? What they've developed is a zero tolerance policy. So there's signs all over the hospital and every doctor's office now. I spent most of yesterday in doctor's offices, so I can tell you there's signs all over doctor's offices too, with a zero tolerance policy, and they go over no sexual harassment, unwarranted language, foul language, blah, blah, no assaultive language, nothing, zero tolerance. So I think that we can have Tom D come back if you want, or somebody.
I'm just brainstorming ideas with you.
Yeah, I'm happy to have, I'm sure he'd be happy to talk about it since they just started it. I don't know how much it costs in signs.
Yeah, I mean, and I know this is largely more a healthcare issue, which is where we sort of get into some of the challenges with the silos of our committee. So I really appreciate the joint hearing that we had, because I am concerned when we had our joint hearing, we heard a lot of really disparate, different systems, different de-escalation tactics, different systems of responding. What it sounded to me like one person was testifying that the Code Green team is 5 people, most of whom are security. I don't know what situation that's ever going to de-escalate. And so I also have a concern, are we responding with a criminal response to something that's actually a training issue or a de-escalation response issue? And my guess is that it's a little bit of both and, but I do think that Senator Hashim's point of like what's happening in different hospitals seems to be just really, really different. And so I wonder if there's space here about you, and again, this is the healthcare issue. This is why the silos are really hard about universalizing some of these practices. And the same is true, because some of what came up for me too is the police response. Based on my reading of this bill, the police already can arrest someone without a warrant for a simple assault, but they're not. And so there's a question too for me of training and response in some of those instances.
I don't think they can.
If they witness it, they can.
I thought
Simple assault you can, if it's unwitnessed.
I thought it had to be felony level. So. Eric?
I'm sorry, I missed that. That was the
Question is, can somebody be arrested for simple assault without a witness?
yes,
It's one of the exceptions, yes.
yes.
Okay. What's the difference between simple assault and aggravated assault?
There's a number of aggravating factors that make it aggravating assault. I can read them to you in a moment.
Serious bodily injury or a weapon.
Yeah. Yep, that's a couple of them. Intent. There's a number of other specific ones. Trying to prevent a law enforcement officer from performing their duty, dangerous weapon, death, serious bodily injury. Those are sort of the aggravating factors that would bump it up from simple to aggravated.
If I said that Senator Bruce hit me, I can then run to Chief Romey and ask him to arrest Senator Bruce.
You could ask.
Nobody witnessed. I mean, I'm asking I realize it sounds funny, but I'm asking a serious question. If that would be simple assault, he slapped me.
Well, generally speaking, there's two sides to a story when you're doing an investigation, okay? And there's circumstances involved during the investigation from the police officer. You come in with a big smile on your face that Senator Bruce just assaulted me. Oh, really? It must have hurt pretty badly. Okay, Senator, seriously. You know, the pain, discomfort has to be involved in it, possibly some minor injuries or whatever else. But I'm going to go to Senator Bruce and obviously give him the opportunity to give me a statement to defend himself in this particular case.
Never happened.
And there's physical evidence, bruises and stuff. And other witnesses.
And the probable cause point is also something to remember, that the rule requires that the officer has to have probable cause to believe that the offense occurred. So I think based on your statements to the chief, Senator Sears, and whatever Senator Baruch would say in his own defense, if it rose to the level of probable cause, then they would have the ability to arrest you, even though they
That
had.
never happened.
Mr. Chair, I'm wondering, in light of the conversation about, especially Senator Hofsky's point about a criminal response. So we started this as joint hearings, and I think that was a good move. I'm wondering if we could pass the bill to them with a series of questions for them to look at or issues for them to take up with regard to it. And I don't know if that would mean formally voting it out or passing it to them prior to a
Formally
formal vote.
voted out with the report of the committee on.
Intact.
We have to check with Senator Lyons
If she wants it. But that way we could cue them to the things that we feel like need discussion, but that are sort of out of our bailiwick.
Do you want to hear from a CEO? And I'm sure Tom's, I don't know if he's available Thursday. We can find some CEO.
We also have attorneys.
You have attorneys?
There are general counsel.
It might be helpful if Thursday, if you could have some attorney check, work with Becky. Yeah, I think you heard the questions. And then I think we'll try to vote on the bill on Thursday, and in between then, hopefully we have a conversation with Senator Lyons, about what she wants to do. Okay.
So can I just clarify? I think, unless I'm missing something, Senator Sears, I'm not hearing any proposed amendments for Thursday.
I don't think there are.
Okay, just making sure I wasn't missing
If
anything.
you're comfortable that HIPAA, I'm sorry, did I miss one?
No, I mean, I would like to have more conversation around the inclusion of disorderly conduct, because I do have
Yeah,
some.
that was part of the.
Yeah, that's what I thought.
discussion for Thursday would be the disorderly conduct and finding out what is actually administrators can do, or what. When I went to the doctor's office yesterday, and I actually went to the lab too, because I had blood work done. And the signs were very, specific at Southwest, both places. I think they're probably new. How are they going to enforce that? That would be one of the questions for the administrators. Zero tolerance policy. I mean, it's one thing for the lady from Prudential to hang up on me yesterday. It's quite another. Remove me from the.
She had zero tolerance for you.
Pardon?
She had zero tolerance for you.
Well, I had zero tolerance for her. It's crazy.